Today I'm going to talk about when should we stop CPR. But before that, I think it's important to talk that if we see death as an enemy, in emergency we are going to get frustrated. Death is a certainty. Yes, of course, we are modern necromancers. When we say reanimate, we're saying bringing someone back to life. So yeah, it's necromancy, but instead of using magic and wishful thinking, we are using science, technology, education to bring the dead back to the living. But before we talk about when should we stop CPR, I think we should define what is a cardiac arrest. It's the sudden and unexpected cessation of cardiac contractility, potentially reversible in a patient without terminal disease. What I want to say is that not every time that the heart stops is a cardiac arrest. Sometimes it's death. And there is a difference between someone who we are going to do CPR and someone we are not doing. So if we think that it's sudden onset, we were not expecting it, we think we can bring back to life, and this patient has the possibility of a long life, yeah, that's a cardiac arrest. Other than that, we're thinking more about death. So before we talk about when should we stop, we should stop in this red light and think, should we start CPR? Why are we doing CPR? And what are the values of our patients? Do my patient prefer to live anyway, or do they want if they have the chance of being in a bed without talking, without their independence, would they want to live? Usually in emergency we cannot have all that information, but once we get, this is a very important data point that we're going to use to define what we're going to do with these patients. So if we start chest compressions, we must know why we are doing chest compressions. What's the goal? The mechanic of it is just a pump. If we are pressing the chest, we are squeezing the heart and trying to make the blood flow. This in itself does not solve the problem of a cardiac arrest. This buys time. This way I'm trying to perfuse my brain, my heart, my organs, so that I can have enough time to find and solve the problem, the adjacencies, the causes of a cardiac arrest. Because it makes no sense just to pump the heart if we are not seeking and fixing the cause that made that heart stop in first place. So let's talk about a case. The paramedics get a patient. It was a run over. The pedestrian was run over by a car. He arrives in our ER and has a cardiac arrest. We are in a rural hospital. We have no surgery, we have no blood bank. So we started looking CPR and we start looking for possible reversible causes. There's no chest lesions, but when we get the ultrasound in the abdomen, we see a lot of free fluid. Is this a reversible cause? I don't think so. If we don't have blood, we cannot substitute the blood the patient has lost. And especially if we don't have a surgical center, we cannot stop that bleeding. So we cannot treat the cause of the cardiac arrest. So am I telling you to withhold care? Yeah, probably. Probably we shouldn't even stop. We are going to start the reanimation, but once we find a cause that's not reversible, should we keep treating? On the other hand, let's talk about a patient, a male, around 50. He comes with chest pain, you get an ECG, you see an occlusion MI, and the patient stops and has a cardiac arrest in front of you. You start your ACLS and you go in this stepwise, step-by-step, drugs, defibrillation, CPR, and you go all go up the stairs. There's one point where you will look and say, what now? I've done all the drugs I had, I'm doing chest compressions, I'm defibrillating, and the patient is still in arrest. What now? So, when should we stop? There is no single answer, but we are going to get some data points that will help us make this decision. One of the most used is the asystole. If you have a patient that's flatlined for the last 20 minutes, probably this heart is dead. And if the heart's dead, probably the patient is also dead. So that's one of the data points that we are going to choose. One that's probably better than it's capnography. For my patient to have CO2 exhaled, this CO2 has to be produced in the cell. So I need oxygen circulating. So I need a pump, I need blood, so I need red blood cells taking oxygen to the cell. And my mitochondria needs to get this oxygen with glucose, and it will produce energy and CO2. And I get this carbonic acid get on my blood and come back to the lung and exhale it. So I need all these steps to have a capnography curve. So if I'm doing good chest compressions, I'm offering oxygen. Why is my capno low? Usually we say under 10, maybe under 8, that's a very low threshold. Probably my cell is dead. My cell is not being able to use the oxygen and produce CO2. So that's another data point that we're going to use. Some guidelines say that if we have good compressions over 20 minutes of low capno, that's probably a good place, a good time to stop care. Another thing that we always look is the pupils, right? The eyes are the windows to the soul. Yeah, maybe not. The open pupils don't say anything to us. They can be a little bit associated with bad prognosis, but it's not guaranteed. There are a lot of cases where patients are in cardiac arrest, the eyes are wide open, and when they recover, the pupils will close, will have mydriasis. So, meiosis, sorry. So, don't use it as a data point to stop care. On the other hand, if you have the closed pupils, that means the patient has signs of life. It's another data point as well as movement, gasping. That means that the cells are alive. And that's a predictor of good prognosis. So open pupils won't tell me to stop care, but closed will tell me keep going. So it's a good data point on this sense. And we have been using a lot point of care ultrasound. This helps a lot, especially we can use it to look for the cause and maybe treat the cause, as well as we can look at the heart. If we see standstill heart, a heart that's not beating, this is a sign of bad prognosis. Also, by itself, it's not enough, but if we add other data points, this is another one that will help us take this decision. So, yeah. And there are some things that are related to time. How long has this patient last seen alive? Was it a witness had cardiac arrest, or he was seen by last time a few hours ago? How long has this patient stayed with no CPR? So the no flow state. This is very important. This is really associated to good neurologic prognostication. So if we have a very low time of no flow, this is very good. Over 10 minutes, probably this brain will suffer if we can revert the cardiac arrest. And what's the rhythm? I already told about asystole, but if we have fibrillation, that means that the cells are alive. So this is a good data point for us to think that we should keep care. But the main question I want to ask when I'm resuscitating someone is, what else can I do? Do I have any other tools in my toolbox, or have I exhausted all the resources I had? So I'll take a look. Have I found the cause? Can I treat the cause? Can I do anything else for my patient, or am I in the highest level of care that I can provide? I want to talk about a case I had recently. He was maybe around 50, male, that had a syncope on his work. We arrived, the patient was pale to the rake, he was slightly tachycardic, his SATs were around low 90s, his BP was okay, he didn't have any chest pain, any neuroscience, there was nothing specific with him, but he looked bad. I got my probe and saw a big VD. So we were thinking about possibly pulmonary embolism. We decided to take him to the hospital. When we arrived in the hospital, we put him in the hospital's bed. And while I was doing the handover, the patient had a cardiac arrest. We started CPR immediately. We got a ETT tube, we were ventilating, doing cardiac compressions, got the mechanical compressor, and we started to thrombolize the patient. We did the drug and kept CPR. We had good capno. We had even the BB cuff was getting good readings. His pupils were closed. He was pinky. He didn't look dead. Even after an hour, we could see the heart trying to squeeze, but after about over an hour of CPR and care, we did a lot of drugs. There was nothing, no other tools in our toolbox. We had to call it. It was really a bummer. Everybody in the room was frustrated. The patient looked like he would be alive and well, but we couldn't restart his heart. Maybe we couldn't solve the problem he was having, and we had to stop it in some time. And I said, okay, yeah, I did all I could. There was nothing else I could do. Unfortunately, the patient is dead. It was not a good sensation. Especially now that we have a lot of technology that can blend life and death. It's not really, with all we have, especially now that we are talking about ECMO and some other stuff, we can keep patients alive indefinitely. We can perfuse them. We can bypass the heart, the lungs. We can provide a lot of things that will keep this person alive for longer. Also, this is a bridge. Our end goal is to treat the cause. If I can't treat the cause, probably I'll have to stop it. I'll have to call it. But if I think my patient has a chance, we have to full send it. Don't just start CPR just for the show, for training. If you start CPR, be sure that you do all you can do for this patient and give him the best chance to come back alive and with a good neurological function. And this is important for us that are working with cardiac arrest. We must ensure, we must fight for our system to provide the best care. And this means that my patient cannot be punished to live in a different zip code. If he lives in Brazil, Sweden, United States, or Japan, that shouldn't matter. He should receive the same tools, the same toolbox in any place in the world. And this is our duty, to study and to change the system so we can provide the best care for our patient. So we can say, yeah, if the patient is dead, I did it all. There was no other stuff that I could have done. And I can put my head in the pillow and sleep comfortably knowing my patient had the best chance. And if he died, well, unfortunately, at this moment in time, there was nothing else that we could have done. We did it all. So remember that not all stop every time that the heart stops, it's a cardiac arrest. Probably we shouldn't start CPR everybody. We should always look for the cause and treat the cause. If we have no way to treat the cause, probably we stop. Other than that, we will use capno, we will use the rhythm, we will use time, and we will use the values of our patient alongside with ultrasound to decide if we are going to do all we can or if we're gonna let this person rest and live from this world. Okay? Thank you.